Chronic obstructive pulmonary disease. That's really two diseases, emphysema and chronic bronchitis. Most patients who have emphysema also have chronic bronchitis, but they are two separate diseases. And COPD is irreversible. Emphysema is characterized by loss of lung elasticity and hyperinflation of lung tissue, so they have big, giant lungs that are not elastic. It causes destruction of the alveoli, and then it has a decreased surface for gas exchange. So all those tiny little alveoli kind of become one big one. So then you have a decreased surface area, and then you have carbon dioxide retention and respiratory acidosis as a result. Chronic bronchitis is an inflammation of the bronchi and the bronchioles due to chronic exposure to irritants. They have they produce thicker sputum, and they have an inability to get rid of it as well. They have difficulty coughing it out. It typically affects middle-aged to older adults. Prevention, we know it's linked to smoking. We know, we want to promote smoking cessation. If a patient or individuals work in areas where in an environment that contains carcinogens, we want to make sure that they have the proper equipment, mask, ventilation, if there's particulates in the air that they're going to be breathing. Our patients who have known COPD, and as our individuals are getting older, our older population, we want to make sure that they have vaccinations, influenza and pneumonia. And older adults have a decreased pulmonary reserve because of their normal changes in their lungs, so that they're at higher risk as well. So, risk factors, I said, age, smoking, it's primary risk factor for the development of COPD. Alpha-1 antitrypsin, ATT deficiency, we see that with our emphysema patients. That's something that's genetic. And then also risk factor of exposure to the air pollutants. So what we see is chronic dyspnea. They'll have dyspnea on exertion, productive cough. Mostly it's most severe in the morning when they get up. They'll have respiratory acidosis with a compensatory metabolic alkalosis. Their lungs, when you listen to them, will have crackles and wheezes, shallow rapid respirations. You'll see them using their accessory muscles. And these individuals, the emphysema patients, will have a barrel chest. And that's when we see the AP, anterior posterior, and lateral diameters are the same. So if you look at an individual, their AP should be half, anterior to posterior should be half of what their lateral is. But with them, they're the same. And if you remind me in class, I'll show you what I mean, because I have a barrel chest, and I'll compare it to somebody else. So when you're percussing these patients, hyperresonance will happen because they have trapped air with the emphysema. They may have an irregular breathing pattern, probably thin extremities, and they get these really enlarged neck muscles from using their accessory muscles to breathe. Dependent edema from right-sided failure, we'll see that when it's advanced. They may have clubbing of their fingers and toes, pallor and cyanosis of the nail beds and mucous membranes, and that's more seen in late stages of the disease. They'll have decreased oxygen saturation levels, decrease between our expected range of 95 to 100. And then you want to make sure that you are aware that anyone who has a darker colored skin or older adults, their saturation levels will be decreased. Okay, let's have a look at the diagnostic test that we use for the pink puffer and the blue bloater. The blue bloater is the bronchitis patient, and the pink puffer is the emphysemic patient. Pulmonary function tests, and I went through these on another lecture already. So they're used for diagnosis as well as determining the effectiveness of the therapy. They compare the forced expiratory volume to the forced vital capacity, and that's to classify the COPD as mild to severe. As the COPD advances, the forced expiratory volume to the forced vital capacity, that ratio will decrease. The expected reference range is 100%. So for mild COPD, the FEV-FVC ratio is decreased to 70%, and as the disease progresses from moderate to severe, the ratio decreases to 50%. We'll also do chest x-rays on our patients to see the hyperinflation of the alveoli. Their diaphragm will flatten out at the late stages of emphysema. And we'll be monitoring blood gases, of course. Hypoxemia with a PO2 less than 80. Hypercarbia, which is a PCO2 of greater than 45. Respiratory acidosis with a metabolic alkalosis compensation. Pulse oximetry, patients who have COPD, usually their levels are less than our expected range of 95 to 100%. And the AAT, which is that alpha-1 antitrypsin levels, we're going to look for a deficiency. This is a special enzyme that's produced by the liver, and it helps regulate other enzymes that help break down pollutants from attacking lung tissue, and these emphysema patients may not have that alpha-1 antitrypsin. So, what do we do for these guys? Well, we want to put them in a position of maximum ventilation, which is 90 high Fowler's at a 90 degrees. I like the guy on the right-hand side. You see how he's tripoding himself? He's put himself in a position of maximum ventilation. We want to encourage effective coughing and suction to remove any secretions. We're going to give them breathing treatments and medications as prescribed, oxygen as prescribed. That blue bloater has his oxygen on there, and he's smoking. Notice how they're both smoking. And let's see what else. We want them to watch for skin breakdown from the oxygen, so we're going to take care of that. And promote adequate nutrition. Because they have an increased work of breathing, they're going to need more calories. Proper nutrition aids to prevent infection. We want to hydrate them. And they have a decreased energy level for eating, so we're going to try and give them soft, high caloric foods to help them get the most for what they can do. We're going to monitor their weights as well. We want to make sure that we can teach them breathing techniques that can help control their dyspneic episodes. So we want to teach them diaphragmatic breathing and pursed lip breathing, and those are both outlined in your textbook fairly well. Incentive spirometry, we want to encourage that for optimal lung expansion. We're going to teach them how to use the IS, and you guys all know how to use that. So teach them how to do that. And they may need 2 to 3 liters of oxygen via nasal cannula or Venturi mask, up to 40% with the Venturi. So they have chronically increased CO2 levels, so we want to make sure that if they have that their oxygen delivery is at the 1 to 2 liters per minute, so that we don't shut down their respiratory center. And we need to watch that their low arterial oxygen levels serve as their primary drive for breathing. We want to cluster their care. We're going to be careful with monitor their limitations, structure their activity around that, provide periods of rest. give the family and patient themselves support. I'm going to talk about the disease and lifestyle changes that have to go on, home care services, oxygen at home, delivery of oxygen, all that kind of thing. Encourage them to verbalize their feelings and increase their fluid intake. They need to drink 2 to 3 liters a day to liquefy their secretions. I want to go back and talk a little bit about verbalization of their feelings. Near their end stage, lung patients have a really hard, they've lost control of everything. They can't even breathe anymore. These patients can develop personality where they're very demanding, or it feels like they're very demanding. Well, they have no control. So they try and control their environment around them the best they can. These patients are the ones that have you come in and do little tiny tasks, or they're really irritated by slight changes in their environment. You just have to roll with it and understand they have lost absolutely everything. Another little anecdotal thing about lung patients is that they love having the fan on them. And there's been research out there trying to figure out if they actually get, if they saturate any better, not oxygen saturation, but do they breathe better because of the fan? And there hasn't been anything proven that it does, but they like the fan on them because it feels like they're getting more O2. So if you'll notice in many hospitals there's fans, and your patient who has lung disease will appreciate having a fan or the air moving towards them. So that's a couple little tips that I can tell you about for those chronic lung patients. Sometimes they can be pretty difficult to deal with. Okay, medications that we use for the COPDers. Bronchodilators are inhalers. The short-acting beta-2 agonist, albuterol. It provides rapid relief. That's their rescue inhaler. Cholinergic antagonists, the anticholinergic medications, Atrovent being one. It blocks the parasympathetic nervous system, and that allows for the sympathetic nervous system effects of increased bronchodilation and decreased pulmonary secretions to occur. The methylxanthines, that's theophylline, old drugs, not used a lot anymore, but we do see it out there. Theodor, it relaxes the smooth muscles of the bronchi, and they require close monitoring because they have a very narrow therapeutic range. We want to monitor these patients for toxicity with theophylline. Side effects include tachycardia, nausea, and diarrhea. Patients who are on albuterol, we're going to watch them for tachycardia and tremors. And the Atrovent patients, they can get dry mouth, so we're going to watch for that. We can give them hard candies, moisten their mouth that way, or encourage them to suck on them by themselves anyway. Okay, anti-inflammatory agents. These medications decrease airway inflammation. Corticosteroids, Flovent, prednisone. If we are giving those systemically, we're going to look for side effects, immunosuppression, fluid retention, hyperglycemia, hypokalemia, poor wound healing. We're going to watch for that. Leukotriene agonists, Singulair, Mast Stabilizer, Intol, and monoclonal antibodies, Xolair. Those can all be used. What else are nursing considerations do I want to tell you about for these ones? I'm not going to go over the steroid stuff again because you guys know that. Plenty of fluids. We want to promote hydration. The steroids, make sure they take them with food. Rinse their mouths if they're using inhalers, that kind of thing. Okay, next, what else did I put on this slide? Respiratory therapy, nutritional support, pulmonary rehab. That's our interdisciplinary care. Respiratory should always be around and consulted for these patients. That's their area of expertise. Nutritional services, we want to talk to them about how we can get the best quality nutrition for these patients. And rehab, pulmonary rehab, great thing. A lot of patients think they can't do anything anymore, and then we can get them into pulmonary rehab. And if you get a chance to ever, you can always go down and have a look at the pulmonary rehab at Tri-City. It's worth a visit. Therapeutic procedures, chest physiotherapy using percussion and vibration. Now you see the respiratory therapists in there with their vibrator. If you look it up in Iggy as well, chest percussion. This is something that we can do as nurses as well that can help loosen secretions and help the patient cough up thick sputum. So it's worth reading that through that, and it is definitely can help the patient. If we put them with head down, feet up, it helps them drain their secretions by gravity. But in all honesty, COPDers do not like to be laid down because they can't breathe. So it works better for asthmatics, I think. That's personal. I don't have any evidence to tell you otherwise on that. So anyways, after our patient has they're discharged home, I told you about how they have loss of control and their powerlessness. We can refer them to any assistance programs, maybe food delivery service like Meals on Wheels. That might be something they could use. Referral services, home care, portable O2. We want them to eat a high caloric food to promote their energy, frequent rest periods. We don't want them to get any infections, so we're going to talk to them about hand hygiene, the importance of taking their medication properly and on time, to stop smoking. However, some of these old lungers, that they're so debilitated by their disease, their one pleasure in life is their cigarette. And I've actually heard pulmonologists understand that they're still going to smoke, so they try and cut down, or they're accepting of their cigarettes. Nicotine is a huge addiction. I talked already about making sure that they're immunized. Influenza, pneumonia, decreased risk for infection. Keep little small children away from them if they're infected, because they are more susceptible. Support. Their complications. Yes, their complications. Respiratory infection, number 1. Result from increased mucus production and poor oxygen levels. We want to make sure that we give them their oxygen, monitor that, give them antibiotics, any other medications if they get an infection. Right-sided heart failure, which is cor pulmonale. That's where we have air trapping, airway collapse, and stiff alveoli. That causes increased pulmonary pressures that are going to reverse backwards, right? So that'll go to the right side of the heart. Because the blood flow through that lung tissue is so difficult, the workload leads to enlargement and thickening of the right atrium and the right ventricle. So we'll see low O2 levels, cyanosis, enlarged tender liver. These are the right-sided failure signs. JVD, dependent edema. We're going to monitor for that. And I also put on this slide another little cartoony guy. I quite like him because he's leaning over his overbed table. Typical posturing for a COPDer. He's got his tissues there because he's going to be coughing out all sorts of sputum. He's got his smoke going and his O2. And he's got those thin little skinny extremities and a big barrel chest.